Hi, welcome. Thanks for spending the day with us learning about single ventricle congenital heart disease. My name is Jamie Colombo, and I specialize in fetal cardiology. That means I'm one of the first people you will meet after you've been told there's a concern with your baby's heart. When you come to the Fetal Heart Center, you'll be greeted by a team of people who are ready to help care for your unborn child. It is our job to determine the diagnosis and lay out the medical, clinical, and emotional journey you and your family will navigate over the course of your child's life. We perform nearly 1,000 fetal echocardiograms per year and diagnose over 20 patients with single ventricle congenital heart disease each year. We understand what a difficult time this is for you and your family, and we are here to guide, educate, and support you in any way that we can. From your first visit to St. Louis Children's Hospital to the day of delivery and beyond, we'll do everything we can to make sure that you and your baby receive the best care possible. Thank you.
Hi, I'm Kim Galbraith, and I'm the nurse coordinator for the Fetal Heart Center here at St. Louis Children's. We understand that hearing that your baby has a single ventricle heart defect can be devastating. And we've learned from our families how important parental well-being and mental health is to the entire family. That's why we've created our Heart Center dedicated perinatal behavioral health program. The idea for this program started with one mom of a single ventricle baby who had the courage to finally speak up and admit to me that she was drowning. It became clear that we needed to do more to support the emotional needs of our heart families, especially those with a single ventricle diagnosis. Studies have shown that mothers who receive a prenatal diagnosis of a CHD have higher levels of depression, anxiety, and even show symptoms of PTSD. Additionally, those women whose babies were diagnosed after birth exhibit similar symptoms. In January of 2018, our perinatal behavioral health program started with one part-time therapist with the goal of reducing the impact of mental health symptoms on parents and infants affected by CHDs. We receive referrals through several different sources, as you can see on the slide. Our therapists provide a variety of services across the continuum of care, including after hospital discharge. And I'm happy to announce that in February of this year, we were able to add another therapist to our team so we can reach even more families just like yours. We know how stressful being a parent can be, especially when your child has a significant heart defect. Our perinatal behavioral health team is here to support the mental health of the entire family. Thank you.
Hello, my name is Blair Culp, and I'm the high-risk infant nurse practitioner. I'm briefly going to talk about our high-risk infant team and our interstage monitoring program. So who are we? The high-risk infant team includes 2 cardiologists, 1 nurse practitioner, and 2 nurse specialists. In addition to the core team, true interstage success occurs with our multidisciplinary approach, including utilization of nutrition, speech therapy, and other services. Now, what exactly do we do? Our goal is to provide high-quality, supportive, and comprehensive care for our single ventricle patients and families during the interstage period. The high-risk infant program continues to grow and evolve to meet these needs. Currently, we conduct inpatient rounds while the high-risk infant is on the TCU and preparing for discharge home. We also hold weekly huddles to review all inpatient and outpatient HRIs. Once outpatient, home interstage monitoring begins with bi-weekly or as-needed check-ins and locus data review between myself and the caregiver. We have weekly HRI clinic on Wednesdays and provide ongoing communication with our primary cardiologist, pediatrician, and home health nursing. Lastly, why and how do we do it? Evidence shows home monitoring during the interstage period reduces mortality, improves nutritional status, and increases family satisfaction. We use Locus Health as our home monitoring platform. As you can see, families are able to enter data into a provided iPad, and the HRI team can then review and trend the data, allowing for early intervention as needed. High-risk infants then transition out of the HRI program following the Glenn or stage 2 palliation. Thank you.
Hello, my name is Dr. Maite Figueroa, and I would like to introduce you to how our involvement in learning collaboratives here at St. Louis Children's Hospital helps us to continually strive to provide state-of-the-art care for our patients and families. One of the first learning collaboratives to be developed in pediatric cardiology was the NPCQIC, or National Pediatric Cardiology Quality Improvement Collaborative. This collaborative focuses on our warriors with single ventricle disease requiring Norwood and Fontan stage palliation. This network now has over 70 centers entering data and working with each other to improve the care for these patients. Many of our services and programs developed for our patients with single ventricle disease, such as our high-risk infant program, have benefited from what we have learned from other centers in this collaborative. There are now more than 10 learning networks, such as NPC-QIC, focusing on the care for congenital and cardiology patients. As depicted on this slide, the Cardiac Networks United represents 7 of these networks. The vision of Cardiac Networks United is to accelerate improvements in health outcomes for patients with pediatric and congenital heart disease by uniting and aligning networks to advance research and improvement efforts through collaboration. Patient data collected by the networks are included on this next slide. Multidisciplinary learning networks can serve as large-scale health system laboratories to engage patients, parents, clinicians, and researchers in testing approaches to translate research into practice. These networks are of particular importance for pediatric research, as evidence to establish safety and efficacy of therapeutic interventions in children is often lacking. I'd like to highlight some of the major accomplishments of the NPC-QIC and the dramatic improvements in outcomes for our patients with single ventricle disease. First, between 2008 and 2016, interstage mortality decreased from 9.5 to 5.3%. Development of a nutrition bundle has led to improved infant growth with a 28% reduction in interstage growth failure. And analysis from data entered into NPC-QIC showed that patients discharged home on digoxin had significantly reduced interstage mortality. Through our involvement in our learning collaboratives, we continue to partner with patients, families, and colleagues to strive to achieve optimal patient outcomes and state-of-the-art healthcare delivery for all. Thank you.
Hello, I'm Justin Robison, a pediatric cardiac intensive care physician at St. Louis Children's Hospital. I wanted to share with you a state-of-the-art monitoring system that we utilize in our ICU. If you've ever been in a hospital room, you know there are monitors that display information like blood pressure, heart rate, electrocardiogram tracings, respiratory rate, and oxygen levels. Often that continuous data is not stored past 24 hours, and in the medical chart, it is recorded every hour, even though it is presented continuously. After heart surgery, kids often need monitoring, including an invasive arterial line with a continuous blood pressure tracing, a central venous line measuring pressures, a ventilator that provides continuous feedback regarding the lungs, including the level of exhaled carbon dioxide, monitors of regional oxygen delivery attached to the head and abdomen, as well as frequent labs drawn from the blood. St. Louis Children's Hospital's cardiac ICU is unique in that it employs a state-of-the-art monitoring system called idiometry. It captures all of this data and displays it in real time for the entire medical team. It stores and displays all of the information for the entirety of your child's stay and is accessible for review instantly. With this information, we can better understand if your child is being adequately supported in their critical state, and also be reassured that they tolerate our reductions in support as they are recovering. I have practiced in other intensive care units that don't employ this monitoring system. And since coming to St. Louis Children's, I feel that idiometry has enhanced my ability to care for the children, and that collectively as a team, we are well prepared to provide the support they need in their most critical hours.
I'm Allison, a staff nurse in the Heart Center and a team lead over patient and family-centered care. In the Heart Center, we are dedicated to continuously improving the patient and family-centered care we provide in unique and various ways. From celebrating a child's bravery and strength by participating in the Beads of Courage program, where they earn different beads that commemorate their medical journey and the courage they showed through each procedure, IV poke, or chest x-ray, to incorporating normal childhood fun into the hospital environment with the use of our warrior cars that can transport children to procedures. We recognize that living in the hospital for a day, a week, or a month bears its challenges on each family. So through our weekly leader rounds, our nursing leadership team tries to meet as many patients and families during their hospital stay to gain feedback on areas the Heart Center is excelling in supporting each family and opportunities in which we can improve, and ultimately learn how we can meet the needs of each patient and family during their time in the Heart Center. Our annual summer and winter family dinners for our inpatient families is one small way we try to show support to our families and hopefully brighten their day. With catered dinner, crafts for the entire family, and some Disney-themed guests, it brings a smile to everyone's faces and helps build precious memories as a family and breaks up the monotony of being in the hospital environment. Lastly, we recognize that a child's family caregivers are an important part of our medical team. We encourage family involvement in daily morning rounds and assisting the team to develop a unique care plan for each child, and joining weekly neurodevelopmental rounds where we talk about therapy goals to work towards and educate on how our staff, therapy services, and the child's family can help each patient achieve their developmental milestones.
Hi there, my name is Manish Agarwal. I'm a cardiologist with a joint appointment in radiology. I have the opportunity to three-dimensionally model each child's unique anatomy. Utilizing CT, MRI, and echocardiographic data, we can often construct a three-dimensional model of your child's heart to plan for the best possible outcome. As you can see here in this model, we can see the intracardiac structures and the extracardiac structures, which help us plan each surgery and best make the child's journey through our hospital the easiest one. We can also take this information and create three-dimensional models, as you can see here, and then these models itself can be used to practice a surgical procedure or any therapeutic intervention that needs to happen. With each of these kids, we take extreme care to make sure that we are planning their surgery to be the best possible situation, and we hope we have the chance to take care of your child. Thank you.
Hello, everyone. My name is Stephen Najat, and I'm one of the pediatric interventional cardiologists here at St. Louis Children's Hospital. I wanted to introduce you all to our cath lab here, as it is very likely that your children will need a procedure at some point during their care here. During a catheterization, we insert soft tubes called catheters from the veins and arteries, usually in the leg or neck, into your child's heart. We do this to help diagnose as well as treat various problems that can arise during the treatment course of children with heart problems, by checking oxygen levels as well as using contrast to take pictures of your child's heart. Additionally, we routinely cath all patients before the second and third stages of your child's repair, as well as some years after the fontan procedure. For some specific patients, we can perform a catheterization procedure in lieu of the first stage of the repair as well. We perform over 500 catheterizations here each year and have an expert team of doctors, nurses, and technicians that focuses solely on the care of pediatric patients with cardiac diseases. When certain vessels are too small, we can use a balloon or a stent to open them up. If there are other harmful vessels that have grown as a result of your child's condition, we can close those off. We very much look forward to participating in the care of your children and hope you enjoy the rest of your day.
Hi, my name is Nate Miller, and I'm the EP nurse at St. Louis Children's Hospital and work with the EP team in the electrophysiology lab. We bring patients to the lab typically due to heart rhythm issues or arrhythmias and can perform procedures such as electrophysiology studies, catheter ablations, and drug challenges. We also implant devices such as pacemakers, ICDs, and insertable cardiac monitors. We have many new technologies available to us in the lab, including contact force sensing tip catheters, which helps to provide a safer and more effective procedure. We also work with a company that uses the HoloLens, a headset that the physician wears during an EP study and ablation to build a 3D holographic image of the patient's heart during the procedure to allow for a better understanding of the child's cardiac anatomy. These are just two of the examples of the many technologies that we use in the lab to give our patients the best possible care here at St. Louis Children's Hospital. Thank you.
Hi, my name is Lisa, and I'm a physician assistant with the electrophysiology team here at St. Louis Children's Hospital. And today we're going to talk about outpatient digital health. You may have met an EP team member if your child required implantation of cardiac devices such as pacemakers, defibrillators, or insertable cardiac monitors. With the advancement of technology, our team is able to remotely monitor these devices, which enhance the care provided by our cardiologists. Through our remote monitoring clinics, we're able to determine that the device is functioning properly or identify potential problems with the device at earlier intervals than routine clinic visits. These reports provide our cardiologists with clinical data to assist in the management of their patients. Occasionally, patients may experience symptoms that are due to an underlying cardiac rhythm abnormality. Current digital health tools, including the Apple Watch Series 5 or 6 and the AliveCore Cardiomobile Monitor, have allowed us to capture the underlying rhythm for these symptoms, thus leading to a more definitive diagnosis. Tracings from these devices can be sent securely to your provider via MyChart. We are using these tools as well as digital stethoscopes to enhance our telehealth appointments. They allow us to obtain a real-time ECG, pulse oximetry measurement, or listen to heart sounds. Our EP providers have weekly telehealth appointments, which has allowed us to continue to care for our patients throughout the pandemic, as well as decrease the travel burden for our patient population that lives greater than 60 miles from St. Louis Children's Hospital. Thank you.
Hello, my name is William Moore, and I'm one of the pediatric cardiologists here at Washington University and St. Louis Children's Hospital. I currently serve as the medical director of the Pediatric Exercise Physiology Lab and Cardiopulmonary Exercise Testing. For me, I've always had a clinical and research interest in exercise performance, exercise testing, and cardiac fitness among patients with congenital heart disease and after heart transplant. Exercise and play is such an important part of a child's life. For some kids, it's a major part of their identity and provides them with a strong social network. The same is true for our congenital heart patients. And when they can't participate in games or sports with their peers, it can have many negative effects. The child or their parents may feel like exercising or exerting themselves is dangerous or something bad might happen, or maybe they just need some guidance on how to get started. And that is exactly what we are creating here at WashU and St. Louis Children's Hospital. We already have the capability of performing exercise stress tests on patients as young as 5 years old, and we perform over 300 tests a year. Although these tests provide valuable information of a patient's exercise capacity, we felt like we could do more. So, collaborating with our exercise physiologist, physical therapist, child psychologist, and nutritionist, we're about to kick off a multidisciplinary approach to overcome those barriers to provide a safe and reassuring environment for patients to learn fundamental components of cardiac fitness and heart health. We will be using this program for any and all children that we think could benefit from this, including the preoperative and postoperative and even post-transplanted patients. This type of program is only found in select major centers across the United States and will be a unique opportunity for our patients here in St. Louis.
Hi, my name is Mary Jane Brogy, and I'm a nurse practitioner with pediatric cardiology and pediatric critical care at St. Louis Children's Hospital, and also a pediatric nurse practitioner in the Cardiac Neurodevelopmental Clinic. The Cardiac Neurodevelopmental Program began at St. Louis Children's Hospital in 2015 with a focus on helping each child with heart disease optimize their neurodevelopmental outcome, reach their fullest potential, and maximize their quality of life. Over the past 6 years, our program has experienced exponential growth and now includes an inpatient program starting at admission to the Heart Center and a more robust outpatient program for children of all ages. Within a few days of admission to the Heart Center, you will meet our inpatient developmental care team consisting of physical, occupational, and speech therapy, a dietitian, neurology, child life specialists, nurses, and me. Our focus is on providing individualized, appropriate developmental care for each patient. Each week, we'll review your child's current developmental needs and give parents and bedside nurses practical ways to care for them. We know that the best thing that we can do for parents and their children is to give them as much of a sense of normalcy as possible. We encourage skin-to-skin care, holding, parental touch, reading and talking to your baby, and infant massage. Our outpatient clinic is for all children who have had cardiac surgery or who have been on ECMO. One of the amazing things about our program is that the therapy team that has followed your child as an inpatient continues to follow along with you as an outpatient. These relationships allow the team to know and understand your child's development on a deeper level. Outpatient visits are in supplementation to your regular cardiology appointments. There are typically 2 appointments in the first year of life, and then usually we see your child once a year afterwards. Of course, if concerns arise, these visits can be as frequently as needed in order to meet your child's needs. Our clinic is multidisciplinary, where each patient is seen by a neurologist, a newborn medicine doctor for kids under 2, physical, occupational, and speech therapy, and a psychologist and cardiologist. We also have a dietitian and a social worker on an as-needed basis. There are a variety of services that we can provide in clinic, including formal developmental testing and screening, early intervention referrals, outpatient therapy referrals, and parenting advice on a variety of topics from sleep concerns to behavioral management. For older children getting ready to enter the school system, we offer neuropsychological testing, help with the IEP process, and advocacy for your child in their local school district. The Cardiac Neurodevelopmental Program knows that just getting your child through discharge from the hospital is not the end of your journey. We are here to help your child and family not only to survive, but also to thrive. Thank you for your time today.
Hello, my name is Dr. Mokshigundam, and I'm one of the pediatric cardiologists and a member of our advanced cardiac support team. We have a team that specializes in caring for children and young adults with heart failure, some of whom may require evaluation for heart transplantation. There are some single ventricle patients who, for one or a number of reasons, may not be good candidates for additional surgeries and may require evaluation for heart transplant. Here at St. Louis Children's, we have one of the most experienced heart transplant programs in the country, with over 30 years of experience in pediatric heart transplantation, including in single ventricle patients. We have transplanted patients at every stage of the single ventricle pathway with good outcomes. As an established leader in pediatric heart transplantation, we also receive referrals from centers across the country for many patients with congenital heart disease that may need evaluation for heart transplant. We are also one of a very small number of centers that performs heart and lung transplants, which may be needed for certain patients. We work very closely with our congenital cardiologists and other members of our multidisciplinary team to identify patients that may need to consider evaluation for heart transplantation. In addition to evaluating and listing patients for heart transplant, we work very closely with our ICU and surgical teams to identify patients that may need additional cardiac support with a ventricular assist device as a bridge to heart transplantation. A ventricular assist device is a mechanical pump that helps the heart move blood through the lungs and body when the heart cannot do it on its own. There are different devices that may be used to do this, some of which exist outside of the body and some of which can be implanted inside of the body, as pictured here. St. Louis Children's has been a leader in successfully implanting ventricular assist devices in single ventricle patients of all ages and stages. In fact, St. Louis Children's was one of the centers involved in the original trial for the Berlin heart, the first ventricular assist device approved for use in children. While the thought of heart transplantation might seem daunting at first, our experienced team is here to work with you and your family through the process and beyond. We have had a lot of great outcomes from heart transplant in single ventricle patients, which have allowed kids to grow, thrive, and live the life they always dreamed of living.
Hello, everyone. This is Mark Grady, your friendly neighborhood pediatric cardiologist. I wanted to talk to you today a little bit about Camp Rhythm. Camp Rhythm is a camp that's been around for over 15 years. It's sponsored by St. Louis Children's Hospital, and it's designed solely for kids with heart disease. It's held each summer for 1 week out at Camp Wyman, which is in Eureka, Missouri, near Six Flags. For the older kids, it's an overnight experience. And for younger kids, we have a day camp experience as well. The camp offers a lot of the things that you would get at any normal camp, like swimming, fishing, zip lines, lots of bugs, and that wholesome camp food. It's staffed entirely by nurses and doctors from St. Louis Children's Hospital so that you know that your child will get the care and supervision that they need, and which you may not be able to get at other camps. And best of all, it's free. So look at this contact information and think about having your kid come and join us. We'd love to see them at the camp. Thank you.
Hello, everyone. I'm Mary Mehegan. I am a nurse at St. Louis Children's Hospital. I am the Fontan Clinic Coordinator. I am also the VAD Coordinator for the Heart Center. I am here to talk about our wonderful Fontan Clinic. So our clinic was to help serve our unique population of Fontan kids and young adults, the St. Louis Children's Hospital Heart Failure Team, Dr. Katie Simpson, and then now Dr. Marion Abera developed a multidisciplinary clinic to provide comprehensive assessment of these unique kids. The clinic opened a few years ago in February of 2018. We have local and referring cardiologists refer their patients to be seen in this clinic. They usually do it around 10 years after their Fontan surgery. To date, we've had around 15 cardiologists refer their patients to us. In our clinic, the clinic patients will be seen by multiple providers. In general, it's cardiologists, nephrologists, hepatologists, pulmonologists, dietitian, and then sometimes immunologists and endocrine will see these patients. What's nice about this clinic is that we room the patient in one room and the providers come in one after another, which is very nice for families not to have to run all over the hospital in different clinic rooms. And it's also really good that these providers can speak to each other about patients, and that can be very beneficial for the kids. The clinic patients will have testing done in the morning and they see their MDs in the afternoon. The testing usually involves some kind of liver imaging, MRI, CT, or an ultrasound. They get labs in the morning, pulmonary function test, and then sometimes some cardiac exams, echo or 12 lead, or sometimes there's other various testing that we do on these patients. Our clinic is held once a month. It's the fourth Friday of every month. It can be a 1 or 2 day visit. Most families really prefer to just put it all in one day and kind of knock it out. The Fontan Clinic patients our intent is to see them around every 3 years. We're just now approaching our 3-year time. So, and then they see their other providers as needed, certainly their cardiologists or other providers as needed in the time in between that. So here's just a quick little slide. We've seen nearly about 60 kids in the last 3 years. We certainly had to cancel some clinics in 2020 due to the pandemic, but we're happy about seeing that we feel like we're off to a good start. I send these families a packet of information with their whole agenda of the day of where to go and what's happening, and then some other forms, but also included in that is some informational flyers about the Fontan Clinic. And these flyers I think are helpful, and it kind of shows why we even have this clinic and why people are seeing these multidisciplinary services and what benefit that is. So they get this flyer, and then there's more information that they get. And then we also have a flyer in our clinic that we can give to our providers that kind of spells out if they have a Fontan patient, when would they might be thinking about referring them to us. So that's it for my slides. I'm really happy to be a part of this clinic. I certainly have been at Children's for a little while, and I used to recover some of these kids post-op. So sometimes every once in a while I'll remember, or somebody will remember me, and that's just really fantastic to have that. And that's it.
Hi, I'm Laura McGinty, and I'm one of the nurse practitioners in the Heart Center. I also work with our adult congenital team that we're fortunate to have here at Children's, BJH, and WashU. Just as we're there for patients and families throughout their childhood, we're also here as patients grow into adolescence and even into adulthood. It's really important that we take steps along your journey in congenital heart disease to start thinking and preparing about being a more active participant in your care, so that as you get older, as an adolescent and as an adult, you are aware of your heart history and you know about your heart needs. We know that if we start early in understanding our heart disease and talking with your cardiologist at doctor's appointments, learning about your medications and learning about the surgeries that you've had, that you'll be a more effective advocate for yourself moving forward. We're very fortunate here at St. Louis Children's Hospital, WashU, and Barnes Jewish Hospital that we also have an accredited Center for Congenital Heart Disease in adults. This means that we have a national accreditation through the Adult Congenital Heart Association as one of the specialty centers in offering patients with congenital heart disease care across the lifespan. We have an exceptional collaboration between the pediatric and adult providers so that we can continue the excellent care that you've been receiving here as you become an adolescent and adult. We're also very fortunate to have a center for women with cardiac disease who are planning on pregnancy or getting ready to start their families. And so with specialized care that we can offer in that regard, we truly are prepared to help you as you continue your journey with congenital heart disease and helping you live your life to the fullest.
Greetings, and thank you for joining us for the last talk of the day. Brave souls, you have endured all the various presentations thus far, and as promised, I will try to keep this one brief. My name is Firouz Ektasadi. Most people call me just Dr. E for obvious reasons, since my name includes almost every vowel in the English language. So a little bit about me. During the day, most nights and weekends, I play the part of a surgeon on the great show called St. Louis Children's Hospital Heart Center. I've been here for about a decade now. Been doing cardiac surgery for about 22 years now. At other times, I play the chief financial officer role for this crazy household called the Ektasadi LLC. The only sane individual in this household is the beautiful woman who is also our chief executive officer and our chief safety officer. It's my wife. And the fellow in the middle, I have no idea who he is because his personality changes from day to day. Maybe it's called being a teenager. All I know is he loves Minecraft and anything digital, math, science, etc. When I first thought about what I would be speaking to you today, I thought I could mention our recent presentation at the annual meeting of the Society of Thoracic Surgeons. I'm very proud of this work because it was reflection of evolution of hard work we've done over the last 10 years to develop techniques and methodology to bridge infants with single ventricle physiology to either recovery or transplantation. This was very well received, and the reason this was exciting is because not too long ago, the outcomes for these infants when folks had attempted the same thing had not been very promising. This is a recent report that reviewed the entire experience in the United States, and you can see, as is stated here, 8 of the 9 patients unfortunately died during the period of time while they were being supported. We modified the way things have been done in the past. We improvised. We took cannulas that were not intended for the purposes that we use them, and we also came up with techniques so we could potentially do these procedures without using the heart-lung machine. This way, the babies could now be babies again. They could be in their mother's arms, they could play, and no longer had to be on ventilator or be essentially bound down in the bed because of concerns for dislodging the typical bypass cannulas that were being used previously. Using this approach, we've been successful in bridging nearly 90% of our infants with single ventricle physiology, and remarkably, 75% of infants that are quite small in size, less than 3 kilograms. We're very proud that other centers around the country quickly, when they learned about these techniques from us, adopted these, and we feel like we've done a great service to many kids, many children around the country. I also thought I could share with you how we've been very fortunate, and since 2019, we've had no mortalities following the Norwood procedure. You can see the statistics for our procedural outcomes in terms of length of stay, the time on the heart-lung machine, etc., in comparison to the data from the Society of Thoracic Surgeons. Perhaps part of the reason why we've had this lucky streak is that some years ago, we initiated a concerted effort to focus and improve our outcomes for the babies with single ventricle physiology, and in particular those with hypoplastic left heart syndrome. Among these being the N100 project, N standing for Norwood, and 100 being our goal of 100% survival at 1 year. We also reached out to other sources of data, such as the single ventricle reconstruction trial data from the Pediatric Heart Network, and studied that to see how we could improve outcomes. We carried out a project that I call it Lean, or Norwood Lean project, where we analyze every one of the surgical procedures we've done, reviewing the videos, and then looking at every single detail of the procedure, the variations and steps and the times that it took. We've been reviewing the angiograms and the CT scans for every baby that has undergone the Norwood procedure and refined the procedure such that we could emulate and achieve an arch reconstruction that looks as much normal as possible. And as part of that, we have a template now that we use that essentially makes the procedure much more reliable. More recently, we've begun a study of the data from the Pediatric Health Information System to try to see if we can gather an optimal approach to management of what we would consider high-risk infants. These are babies that are born at less than 2.5 kilograms or less than 35 weeks in gestational age. Essentially, we're trying to find out, is there an optimal approach by looking at the data from various centers and different approaches to see, for instance, is it optimal to approach these infants just straightforward with Norwood procedure, or to attempt some alternative palliative procedures that folks have suggested, such as bilateral PA banding or the standard hybrid approach, or even keeping babies on prostaglandins until transplantation. I also thought I could share with you how we're proud that we've had one of the most successful heart-lung transplant programs in the world, for that matter. On this wonderful card that sits on top of my wall, and I keep adding additional pictures, you can see the top left-hand corner. The little fellow with the awesome hairdo is he's now about 2.5, 3 years out. He originally was born with hypoplastic left heart syndrome, intact atrial septum, and bad tricuspid valve regurgitation, and was declined by a number of really excellent centers in the country because they thought it was not likely to result in a good outcome. And I'm really proud that we were able to get him through some very difficult events during his hospital stay, and he's thriving and he's doing great now. But as I was recording all this and reviewing all my slides, I thought to myself, how relevant or how important will all this information be to you? And not to get philosophical, but really thinking about, does this really matter? The truth is, what matters, what I think for all of us, is that we all want to matter. And I think as parents, we want to know that our children's lives are important and that they matter. And I think at the end of the day, what's really most important for us is seeing these kids be just kids, whether they want to be a jokester, a bookworm, they want to become a scientist or a nurse or a firefighter. This is what excites us. One of the most exciting times of the year for me is during the holidays, when I receive the cards from various families. And whenever I get up to go to the OR, it's a reminder of, no matter what, this is really what it's all about. Everyone knows Albert Einstein. Most of you know him as a physicist, but in fact, he was even a more brilliant mathematician. He started essentially studying math and completed calculus when he was only 12 years old. There's a great quote by him saying, "Not everything that can be counted counts, and not everything that counts can be counted." I think from someone who knows math pretty well, that's an important and profound statement. In fact, when I was reflecting on this presentation, I thought mathematics is quite relevant to what I'm speaking to you about. You see, in mathematics, there's this thing called absolute value. Absolute value of any integer, whether if it's negative or positive, is just that value, it's just that number. So whether if it's a -1 or a +1, the absolute value is just 1. Today, you heard from many of our providers, many of my teammates, and you've come to appreciate the vast group of individuals, multidisciplinary teams that are involved in the care of patients with single ventricle physiology. I hope you've come to realize that we're committed to providing the best possible care, and we're doing everything possible to continue to improve. Truth is, nothing ever stays the same, and change is an inevitable part of life, which is not necessarily a bad thing, but it does mean that we will have to continue to learn and we have to continue to become better. And because of that, it's inevitable that some days we're going to get a +1 and other days we're going to get a -1. But at the end of the day, really the only thing that counts, it's the absolute value of what we're trying to do. And that really is absolute good. And I want to finish by putting into context this concept of absolute good. Thomas Keneally, who is the author of the book Schindler's Ark, which was the premise based on which the movie many of you may have heard about, the Schindler's List, in his book writes, the list is an absolute good. The list is life, and how everything else around it is really not that important. In closing, thank you for taking the time to spend part of your Saturday with us, and I wish you all well.